Female Genital Mutilation and its Management. Green Tab Guideline Number 53, July 2015. Introduction and Background Epidemiology. Definition and Classification. Female genital mutilation, also known as female genital cutting, refers to all procedures involving partial or total removal of the external female genitalia or other injury to the female genital organs for non-medical reasons. The widely accepted classification of female genital mutilation is developed by the World Health Organization or WHO in 1995. Table number 1. World Health Organization Female Genital Mutilation Classification. Type 1. Partial or total removal of the clitoris and or the prepuce or the clitoridectomy. Type 2. Partial or total removal of the clitoris and the labia minora with or without excision of the labia majora or excision. Type 3. Narrowing of the vaginal orifice with creation of a covering seal by cutting and a positioning the labia minora and or the labia majora with or without excision of the clitoris or the infibulation. Type 4. All other harmful procedures to the female genitalia for non-medical purposes, for example, pricking, piercing, incising, scraping, and cauterization. Global epidemiology. UNICEF estimates that worldwide, over 125 million women and girls have undergone female genital mutilation. The type of FGM or female genital mutilation varies between countries. FGM type 3 or de-infibulation is practiced almost exclusively in Africa. FGM is almost always carried out on girls between infancy and the age of 15, but the age at which girls are mutilated varies considerably between countries. It is estimated that in over half of countries practicing FGM, girls are cut under the age of 5 years. In some communities, adult women may undergo re-infibulation following childbirth. Complications of female genital mutilation. Clinicians should be aware of the short and long-term complications of FGM. Short-term complications. The most common immediate complications from FGM were haemorrhage, 5 to 62%, urinary retention, 8 to 53%, and genital swelling, 2 to 27%. Long-term complications. Genital scarring. Genital scarring after FGM can be unsightly and painful. Keloid scarring has been reported in up to 3% of women. Epidermoid inclusion cyst and sebaceous cyst may need surgical excision. Neuroma of the clitoris causing pain has been described. Urinary tract complications. Lower urinary tract symptoms are more common in women with FGM, particularly those with type 2 or type 3 FGM. Poor urinary flow beneath the infibulation scar may result in symptoms of urinary obstruction, and stasis of urine may lead to recurrent urinary tract infection and to urinary or vaginal calculi. The recommended treatment is de-infibulation. Damage to the urethra during FGM of any type may result in a urinary stricture or fistulae. This requires assessment by a urologist or urogynaecologist. Dyspareunia, aparunia, and impaired sexual function. Dyspareunia may occur as a result of vaginal narrowing and painful scar tissue. Apareunia and vulvovaginal lacerations during sexual intercourse have also been reported. The removal of sexually sensitive tissue, such as the clitoris and labia minora, may reduce sexual sensation, while scarring over the clitoris may be painful. Psychological sequelae. It is accepted that FGM has psychological effects, and flashbacks, anxiety, and post-traumatic stress disorder have been reported. Menstrual difficulties. Hematocolpus due to FGM has been reported. Dysmenorrhea has also been reported among women with FGM, although the underlying mechanisms are unclear. Genital infection and pelvic inflammatory disease. FGM has been associated with an increased risk of bacterial vaginosis and herpes simplex virus type 2. However, currently, there is no conclusive epidemiological evidence to support an increased risk of pelvic inflammatory disease as a consequence of FGM. Infertility. Potential factors could include lack of sexual intercourse, such as apareunia, dyspareunia, and impaired sexual function, and ascending infections caused by the FGM procedure. HIV and hepatitis B infection. Many FGM practicing countries are hepatitis B endemic, and some have a high prevalence of HIV. Obstetric complications. The meta-analysis reported an increased risk of prolonged labor, postpartum hemorrhage, and perineal trauma. The World Health Organization study also found an increased risk of cesarean section and demonstrated an increased need for neonatal resuscitation and risk of stillbirth and early neonatal death. The legal and regulatory responsibilities of health professionals. Female genital mutilation and United Kingdom law. All health professionals must be aware of the Female Genital Mutilation Act of 2003 in England, Wales, and Northern Ireland, and the Prohibition of Female Genital Mutilation, Scotland Act of 2005, in Scotland. Both acts provide that female genital mutilation is illegal unless it is a surgical operation on a girl or woman irrespective of her age. A, which is necessary for her physical or mental health, or B, she is in any stage of labor or has just given birth for purposes connected with the labor or birth. It is illegal to arrange or assist in arranging for a UK national or UK resident to be taken overseas for the purpose of FGM. It is an offense for those with parental responsibility to fail to protect a girl from the risk of FGM. If FGM is confirmed in a girl under 18 years of age, either on examination or because the patient or parent says it has been done, reporting to the police is mandatory, and this must be within 1 month of confirmation. Female genital cosmetic surgery, or FGCS, may be prohibited unless it is necessary for the patient's physical or mental health. All surgeons who undertake FGCS must take appropriate measures to ensure compliance with the FGM Acts. Re-infibulation is illegal. There is no clinical justification for re-infibulation, and it should not be undertaken under any circumstances. What are the legal and regulatory responsibilities of health professionals in their evaluation of women with female genital mutilation? When a woman with FGM is identified, the health professional must explain the UK law on FGM. The health professional must understand the difference between recording, documenting FGM in the medical records for data collection, and reporting, making a referral to police and or social services and their responsibilities with regards to this. The health professional must be familiar with the requirements of the Health and Social Care Information Center or HSCIC FGM Enhanced Dataset and explain its purpose to the woman. The requirement for her personal data to be submitted without anonymization to the HSCIC in order to prevent duplication of data should be explained. However, she should also be told that all personal data are anonymized at the point of statistical analysis and publication. The health professional should be aware that it is not mandatory to report all pregnant women to social services or the police. An individual risk assessment should be made by a member of the clinical team, a midwife or obstetrician, using an FGM safeguarding risk assessment tool. If the unborn child or any related child is considered at risk, then a report should be made. What are the principles of female genital mutilation management in obstetric and gynecological practice? All acute trust health boards should have a designated consultant and midwife responsible for the care of women with FGM. All gynecologists, obstetricians, and midwives should receive mandatory training on FGM and its management, including the technique of de-infibulation. They should complete the program of FGM e-modules developed by Health Education England. Specialist multidisciplinary FGM services should be led by a consultant obstetrician and or gynecologist and be accessible through self-referral. These services should offer information and advice about FGM, child safeguarding risk assessment, gynaecological assessment, de-infibulation, and access to other services. Health professionals should ensure that, in consultations with women affected by FGM, the consultation and examination environment is safe and private, their approach is sensitive and non-judgmental, and professional interpreters are used where necessary. Family members should not be used as interpreters. How should recent female genital mutilation be managed? Healthcare professionals should be vigilant and aware of the clinical signs and symptoms of recent FGM, which include pain, haemorrhage, infection, and urinary retention. Examination findings should be accurately recorded in the clinical records. Some type 4 FGM, where a small incision or cut is made adjacent to or on the clitoris, can leave few, if any, visible signs when healed. Consideration should be given to photographic documentation of the findings at acute presentation. Legal and regulatory procedures must be followed. All women and girls with acute or recent FGM require police and social services referral. How should female genital mutilation be managed in gynecological practice? What should the referral pathway be for women with FGM? Women may be referred by their general practitioner to a hospital gynecology clinic. The referral should be directed to FGM services if available, or to the designated consultant obstetrician and or gynecologist responsible for the care of women and girls with FGM. Women should be able to self-refer. All children with FGM or suspected FGM should be seen within child safeguarding services. How should women with female genital mutilation be assessed in gynecological practice? Women with FGM may present with symptoms directly attributable to their FGM or with coexisting gynecological morbidity. Gynecologists should ask all women from communities that traditionally practice FGM whether they have had the procedure. Clinicians should be aware that psychological sequelae and impaired sexual function can occur with all types of FGM. Examination should include inspection of the vulva to determine the type of FGM and whether de-infibulation is indicated, as well as to identify any other FGM-related morbidities, for example, epidermoid inclusion cyst. All women should be offered referral for psychological assessment and treatment, testing for HIV, hepatitis B and C, and sexual health screening. Where appropriate, women should be referred to gynaecological subspecialties, for example, psychosexual services, urogynecology, and infertility. Gynecologists should be aware that narrowing of the vagina due to type 3 FGM can preclude vaginal examination for cervical smears and genital infection screens. De-infibulation may be required prior to gynecological procedures such as surgical management of miscarriage or SMM or termination of pregnancy or TOP. What is the role of de-infibulation in gynecological practice? Women who are likely to benefit from de-infibulation should be counseled and offered the procedure before pregnancy, ideally before first sexual intercourse. Women offered de-infibulation should have the option of having the procedure performed under local anesthetic in the clinic setting in a suitable outpatient procedures room. De-infibulation is a minor surgical procedure to divide the scar tissue sealing the vaginal introitus in type 3 FGM. De-infibulation is sometimes termed a reversal of FGM. However, this is incorrect as it does not replace genital tissue or restore normal genital anatomy and function. De-infibulation is recommended if the introitus is not sufficiently open to permit normal urinary and menstrual flow, vaginal examination, comfortable sexual intercourse, and safe vaginal delivery. It may also be necessary to permit cervical smears, sexual health screens, and gynecological surgery. In practice, it will be required for most women with type 3 FGM as the vaginal introitus will be narrowed. What is the role of clitoral reconstruction? Clitoral reconstruction should not be performed because current evidence suggests unacceptable complication rates without conclusive evidence of benefit. How should female genital mutilation be managed in pregnancy? What level of care do women with FGM require? Women with FGM are more likely to have obstetric complications, and consultant-led care is generally recommended. However, some women with previous uncomplicated vaginal deliveries may be suitable for midwifery-led care in labor. How should women with FGM be identified in pregnancy? All women, irrespective of country of origin, should be asked for a history of FGM at their booking antenatal visit so that FGM can be identified early in the pregnancy. This should be documented in the maternity record. Women identified as having female genital mutilation or FGM should be referred to the designated consultant obstetrician or midwife with responsibility for FGM patients. Local protocols will determine which elements of care should be undertaken by these individuals and which may be undertaken by other appropriately trained midwives or obstetricians. What antenatal documentation is required to demonstrate that legal and regulatory processes have been adhered to? The midwife or obstetrician should ensure that all relevant information is documented in the clinical records. How should antenatal care be managed? Referral for psychological assessment and treatment should be offered. The vulva should be inspected to determine the type of FGM and whether de-infibulation is indicated. If the introitus is sufficiently open to permit vaginal examination, and if the urethral meatus is visible, then de-infibulation is unlikely to be necessary. Screening for hepatitis C should be offered in addition to the other routine antenatal screening tests such as hepatitis B, HIV, and syphilis. De-infibulation may be performed antenatally, usually in the second trimester, typically at around 20 weeks of gestation, in the first stage of labor, or at the time of delivery, and can usually be performed under local anesthetic in a delivery suite room. It can also be performed perioperatively after cesarean section. The midwife or obstetrician should discuss, agree, and record a plan of care. This may be documented in a pre-formatted sheet. Women should be informed that re-infibulation will not be undertaken under any circumstances. For women with type 3 FGM, where adequate vaginal assessment in labor is unlikely to be possible, de-infibulation should be recommended antenatally, usually in the second trimester, typically at around 20 weeks of gestation. Antenatal de-infibulation as an elective procedure ensures that the procedure is performed by an appropriately trained midwife or obstetrician. However, women may prefer de-infibulation during labor. How should intrapartum care be managed? If a woman requires intrapartum de-infibulation, the midwife and obstetrician caring for her should have completed training in de-infibulation or should be supervised appropriately. If de-infibulation plan for the time of delivery is not undertaken because of recurse to cesarean section, then the option of perioperative de-infibulation, for example, just after cesarean section, should be considered and discussed with the woman. Labial tears in women with FGM should be managed in the same manner as in women without FGM. Repairs should be performed where clinically indicated after discussion with the women and using appropriate materials and techniques. In contrast to de-infibulation pre-pregnancy, antenatally or in the first stage of labor, when either a scalpel or scissors may be used, at delivery, the incision should be made with scissors rather than a scalpel just before crowning of the fetal head. Lidocaine without adrenaline or epinephrine should be used. Once the procedure has been performed, the need for episiotomy should be assessed. This is commonly required due to scarring and reduced skin elasticity of the introitus. How should intrapartum care be managed for women identified as having FGM in pregnancy for whom there has been no agreed documented plan of care? The impact of FGM on labor and delivery should be sensitively discussed and a plan of care agreed. If vaginal examination is not possible or intrapartum procedures and urinary catheterization are not feasible, then de-infibulation in the first stage of labor should be recommended. An epidural should be offered to cover the procedure and for subsequent examinations and delivery. If vaginal access is adequate, then de-infibulation can be performed at the time of delivery under local anesthetic. How should postnatal care be managed? A woman whose planned de-infibulation was not performed because of delivery by cesarean section should have follow-up in a gynecology outpatient or FGM clinic so that de-infibulation can be offered before a subsequent pregnancy. The discharging midwife should ensure that all legal and regulatory processes have been adhered to prior to discharge.